I'm delighted to moderate this panel of practitioners and experienced and skilled folks who will be eager to share some of the models and thinking around housing. So really focused on the issues of housing. You heard people talk about it in the morning. I was interested to see in Dr. Manchanta's slides how he also lifted up residential segregation, which is a huge issue in our region. So just to set the table here, and spoiler alert, none of the news is good around housing. We are in an affordability crisis. We are in a supply crisis. And the demographic background to our region is that we've actually been losing population, and housing cost is no doubt a factor in that. Domestic outmigration has been resulting in people moving to different parts of the region and different parts of the state. And the only reason that we have seen any kind of an increase is due to international migration. So people coming in to new arrivals, primarily people of color, but this is the reason why we have continued to have some workforce, some ability to keep our economy going is through that international migration. We are a very unaffordable region. If you think about people who make below $75,000 a year, and I know most of our seniors make far below that, those households, 75% of those households are paying more than half of their income towards rent. Unsustainable and just unaffordable. It leads to other issues like food insecurity and a lot of health outcomes. We also know that we are racially segregated. Within the 351 cities and towns, only 5 cities and towns account for 50% of people who are Black. Only 10 cities account for 50% of people who are Latino. So there's a concentration of racial and ethnic minorities, racial and ethnic groups. And given the systemic inequities and the housing discriminatory system, these are often lower income communities than those around them. So this is the backdrop for our seniors, our lower income seniors who are aging in this community, facing all of these challenges in addition to the fact that they have healthcare needs and they have, they could be dealing with social isolation and a host of other factors. But this is, at a basic level, the challenges, the housing challenges that we have. The bright spark, one of the bright sparks in our state came on August 6th when the Affordable Homes Act was signed as the housing bond bill. And it authorizes $5.1 billion in funding and a series of policy proposals, policy initiatives. So let me start with you, Lisbeth, to talk to us a little bit about the Affordable Homes Act, I'll refer to as at AHA, and how it will help address the housing crisis for low-income families and seniors in particular.
Thank you, Soni.
I also want to, sorry, let me just mention, Lisbeth is president of Two Life Communities.
Recent change for me,
Yeah.
Thank you. So I'm primarily going to focus on older adults and the impact of this truly landmark bill on older adults. But I think it's fair to say foundationally that, whether you're dealing with housing for older adults, for families, for individuals, for folks who are homeless or formerly homeless, it's really an integrated approach. And any place in the system you intervene helps, I think, the entire system. So today, with the focus on talking about older adults, I want to start by fast-forwarding us all 10 years and remind us that for the first time in the history of this country, the population of older adults will exceed the population of people under 18. And fast forward another 10 years, and the population of older adults will make up about a quarter of the population in the United States. So following up on a theme that I think we heard in the panel before, the time is now to act. because it takes a long time for the systems and the infrastructure and the administration and the organizations to ramp up what's necessary to really meet the need. And the bond bill, which is the largest bond bill to support housing production in the state's history, is a huge step in doing that. And in addition to this tremendous increase in funding, the bond bill has 3 special commissions that were named that are going to study the way to leverage these fabulous resources to really impact populations that have need. And those 3 commissions, one is on senior housing, which is a lot of what I'm going to focus on today in terms of what that commission can do and the opportunity there. But companions to that, and again, it's all a really integrated approach, are looking at issues of accessibility and adaptability in housing, which is certainly an issue and a need that faces older adults, especially since within our existing housing infrastructure, which is quite old, the lack of accessibility is a huge barrier to people being able to age where they are and age well and not become isolated and really confined. And then the third one is a commission to study extremely low-income housing needs. So 3 hugely important topics that all certainly impact senior housing. And to bring some of those data statistics, back to Massachusetts, and I apologize for not being here earlier. If these things got cited, it can't hurt to say them again because they're important. But 65% of Massachusetts older adults earn less than 50% of the area median income, and another 15% are less than 80% of median income. So we are talking about an income-constrained population, and it's no surprise that Massachusetts has the highest degree of elder economic insecurity in the entire country. And we think, and that's a UMass statistic, we think that's caused both by the combined high cost of housing in this state, but also the cost of health care and home care. And it was so important to hear the conversation about home care and LTSS in the earlier conversation, because we can't talk about supporting older adults without talking about the need for home care and how we deliver that. And the median income of older adults in this state is about $32,000, yet that same UMass study says it takes minimally $60,000 to just meet basic needs if you're an older adult living in this state. So people are living with half or less of what's needed just to pay for food and basic medicine and basic transportation. So it's also no surprise, and I didn't recheck the statistics, so we're either number 1 or 2, but either one, it's bad, in the rate of nursing home placements per capita in this state. Among the entire country. And again, that's not because our elders in Massachusetts are more frail. It's because it's the only place that they can go when they run out of money to get their housing and their care paid for in a better way. So now I'm going to fast forward us back to the Senior Housing Commission and just set the stage for we actually can do it. At Two Life Communities, we've been around for over 60 years. We are a supportive housing organization. It's independent living, but I think we would argue that we, through our comprehensive approach to aging, are able to provide everything that people need. And I'll get to the model more later in remarks, but the question is, how do we produce more housing with these fabulous bond bill dollars that meets the comprehensive needs of older adults? And that's, really talking about housing that's fundamentally affordable, housing that's adaptable, a housing platform that has resident service coordinators and care coordinators that know the people who live with us and can coordinate and work with the LTSS providers, the healthcare providers that can serve people's needs where they live, and engaging programs and services that really combat loneliness, because loneliness, as we know, has a huge negative impact on people's health. It accelerates dementia, heart disease, diabetes, all kinds of conditions, and for supportive housing to work well, also, we want this study this commission to study how housing is a platform for bringing site-based healthcare and site-based home care into efficient platforms where people live, so we can bring down those costs also. Beyond the capital funding that's in the bond bill to actually build this housing, we also need to talk about the operations side, which really gets to how much people can pay for rent and what it actually costs to operate housing, because people who are extremely low income, paying only 30% of their income isn't enough to even pay the basic bills and the basic maintenance. So if we want to have the housing be sustainable over time, we've really got to talk about 100% project-based Section 8 or MRVP within housing if we're going to meet the needs of the people that we're here to talk about today, and to really look at the fabulous infrastructure of SCO and PACE organizations we have in the state and how we bring them to the table in this production work to create truly comprehensive approaches to supportive housing. So we're really excited to be on this. I know others in the room hopefully will participate in that, but I think pairing capital resources in a bond bill in such a dramatic way with innovations on the policy and delivery side, really we're at this tremendous moment where we can do things differently and do things smarter that will have real impact.
Thank you, Elizabeth. And I'll just add, MRVP is the Massachusetts Rental Voucher Program, for anyone who may not be familiar. And it's the pairing of subsidy to cover some of those operating costs that Elizabeth was talking about. And I'll also just note that accessibility is a particular issue in our region because we have some of the oldest stock in the country, and as a percentage of our housing stock, and part of the reason is that we haven't been building enough since 1960. So our older stock is, the triple deckers and the two families, inaccessible, hard to make accessible, hard to build out for modifications so that people can age and pay. So that's just sort of an underlying challenge for our region. So let me turn to you, Betsy. You were formerly an attorney with Greater Boston Legal Services, now the Executive Director of Mass Aging Access. You're completely familiar with the challenges that older adults face and low-income families. And you also fully understand supportive housing models and the unique role that they play in serving particularly aging adults with complex needs. Can you talk a little bit about the existing supportive housing network and also the potential for partnerships to increase this housing and service nexus?
Sure, I'd be happy to, but I want to start by saying I'm absolutely thrilled and want to thank Marta and Colleen for actually adding a housing session. It's so rare when you're talking about affordable housing that older adults' needs are ever mentioned, let alone addressed. So thank you very much. This is we will use our 55 minutes very wisely and hope to have more discussions over time, because I actually disagree a little bit with the demographics discussions we've been having. We have known for a long time that this wave was coming, and the fact is we did not prepare for it. We shouldn't be passing a housing bond bill now and creating housing 4 or 5 years from now. We should have done it 10 years ago. So we find ourselves in this position. We find ourselves in a position where, and I don't even mean that as a criticism of the bond bill, because it's absolutely amazing. It's coming at a critically important time for sure, but right now, I think the focus as affordable housing is being funded and built over the course of the next few years. How do we keep people who are struggling to remain independent, struggling with behavioral health issues, at risk of losing their housing, at home, independent where they want to be, living as healthy as possible with the highest quality of life? And I think the perfect model for that is supportive housing. We're really fortunate in Massachusetts because we have several different supportive housing models. Two Life has an absolutely incredible model. I always joke that when I get to a certain age, I'm going to get on their waiting list. Hebrew Senior Life that's here today has a model. The PACE plans are being embedded in senior housing, which is another really innovative, interesting model. The ASAP model, which I'm most familiar with, is actually a line item in our state, in the EOEA budget, in our state budget. We get funding from the state to provide services to over 9,000 residents in, I think we're in 105 buildings now. And regardless of the model, the really and most essential aspect of all of the models is the on-site presence of somebody who is a helper, somebody who cares. I think when you're talking about health-related social needs or addressing health disparities, the most important piece of that conversation is trust. Because there's services, and then there's somebody's willingness to accept services. So first you have to make services available and let people know what they are and how they can access them. But if somebody's unwilling or unable because they've had so many broken promises, they've been overpromised and underdelivered most of their life, having trust, which can lead to engagement, which can then lead to acceptance of services, is crucially important. And somebody whose job is to wake up every day and go on site to housing, to be that friendly person who's not there to meddle, not there to force, but rather to, present choices, I think is really the secret sauce in the supportive housing model. With the ASAP model, what's really terrific is you've heard a lot about ASAPs today, and my job is to be the prime cheerleader for the ASAPs, and that is a really easy task for me because my prior work worked alongside ASAPs, many of whom were embedded in senior housing, supportive housing models over the years, and I have an enormous amount of respect for the work that people on the ground do. And I fully understand the value of trying to work with a client who's at risk of eviction in a building without a resident service coordinator and one where there is a resident service coordinator. And that is very much about the trust relationship that's been established between that employee who works for an ASAP but who goes every day to the building and shows up every day and is there to also serve as a navigator or a bridge back to his or her agency where there's a whole array of services that, as many people call the ASAP network, the best kept secret in Massachusetts, that people don't even know exists. And I could just give one quick example out of many, many cases I've had that are very similar, but an older adult who finally told the resident service coordinator that she had some papers that she got, which turned out to be not just an eviction notice, but a court date, who's being evicted because of lease violations due to hoarding. Resident service coordinator immediately made a protective services referral back to her agency, one of her colleagues. The two of them spent an enormous amount of time talking and developing trust and working with the tenant, who finally allowed them to make a legal services referral to my agency, another free legal service that ASAPs provide to their members. Ultimately, there was heavy chore services. ASAP paid for it. There was ongoing cleaning and homemaking service, ASAP service. They also discovered that the tenant was food insecure. So there was home-delivered meals. There was a SNAP application. She hadn't paid bills in a while, was struggling to do that. A money manager was brought in. And the goal obviously was to stave off the eviction, make it go away. But the ultimate goal should always be, how do you preserve that housing long term? How do you try to get not just at that legal problem, but at the root of the legal problem? And that's where I think the ASAP network is absolutely essential, to be able to go back and look at, you need this, this, and this, and we can bring it in. And the bridge, the resident service coordinator, could get that in very quickly. And if you speak Spanish, we'll bring in someone who speaks Spanish. Needs get met relatively quickly, and that's the key. And other residents see that, the trust relationship grows in the building, and it really is the perfect platform to integrate both the healthcare services that we've been talking about today, along with everything I mentioned is an essential service for somebody to live independently, and it's not a healthcare service, it's a social care service. And that is really the place where I think those two services can intersect and work together to both help in crisis situations like an eviction, but also in day-to-day. How do you keep your eyes on somebody who's high risk? So you're not automatically just getting in the ambulance and going to the hospital, or someone who's rising risk. How do you keep your eye on that sort of difficult son who's come around and might be taking mom to the bank? Everything that happens day to day, there's a set of eyes on there, a set of caring eyes, and that is, again, the secret sauce.
Yeah, thank you, Betsy. Thank you for raising the issue of trust and also the language, cultural competency that goes around being able to build that trust. I also valued hearing it from the previous panel about how the person, the home health person, is really almost your primary care physician and everything built into one because they have the that deep connection with people. Let me turn to you, Dr. Wong, just to ask about, we hear housing is healthcare, and we know that housing is probably one of the most primary social determinants of health. Can you talk a little bit more about this connection and what you're seeing as some of the housing challenges for folks you see at the Dimick Center?
Can everyone hear me?
Yeah.
Okay, perfect. I do want to go into a nursing home. I spent my entire career making those places better. So if I say I don't want to go into a nursing home, I feel like my whole career has been wasted. So I have to just, I had my hand up at the back, but just in case no one saw me, I have to say. And I also think PACE is the best kept secret, not ASAP's, but okay, that's something. So, no, I want to just anchor this discussion in a few layers, right? When we think about housing in lay terms, we really are thinking about where someone lives. From a medical paradigm, a home is not just where someone lives, it's the place that anchors them to the entire ecosystem of their healthcare delivery. What do I mean by that? The home is what allows them access to the communities that support them. Their homes are what allow them to be connected with their religious institutions that support them. Their homes are what allows them to be close to getting their groceries and therefore reducing food insecurity. Their homes is what allows them to be able to go to a pharmacy and get their medications. Their homes is where their grandkids come to visit. Their homes is where their neighbors check on them. Their homes is where they're able to see the dogs around the neighborhood that they're able to pet because they are no longer able to be mobile enough to keep their own animals. So when I think about the connection between housing and healthcare, I think of it in a much broader context than just where someone lays their head at night. It really is the anchor by which they exist, by which they're able to have a quality of life that is decent, but it also impacts directly not only their longevity, but it also impacts their morbidity, and it impacts their mortality. So it truly is an entirety of who their existence is, that place that is their zip code. And I often will say to trainees after they've been in and seen a patient and come back, and I'll say, tell me a little bit about their home. And they'll say, oh, I didn't really get to that. And I'll send them back in because I just feel it's so critical for us during that medical interaction to be able to learn what home means to that individual, because we wouldn't be able to support them unless we understand that. So that's the piece that I often like to start off with. What is the definition of home? What's the definition of someone's housing, to be able to understand the link with healthcare? The second piece is, once you get inside that home, what does it have to be able to make that person live their best life for where they are in life? And I see Randy Berkowitz here. I'm going to call you out because this story is going to come back full circle. So it's 2003. I'm a fellow in the Division on Aging. Randy's one of my preceptors, and I'm 2 years here from England. And I'm doing a home visit with another preceptor. And we visit three sisters who live together in Cambridge, no other family but each other. They're 88, 92, and 95 years old, and I'll never forget this. And it's winter, and I go into their home, and I'm very excited because my preceptor, Dr. Alan Abrams, has told me a lot about the interpersonal relationship between the three of them, who runs the show, who controls each other, and I'm really excited. But what he did not prepare me for is what I was going to walk into. I walked into three sisters sitting on a sofa in absolute darkness at 5 p.m. on a winter's day, no lights on in the entire house, and so frigid that I could barely stay in there myself. And I just remember thinking to myself, to live 95 years and end life this way, how very tragic. Tragic not only for the individual, but tragic also for the community and tragic for the State of the Union, because this is a failure of our responsibility to be able to address housing so that folks who have obviously committed their lives to giving something into that system don't end up at the end of life in a house that is dark and cold and literally would be accelerating their death beyond anything high blood pressure, diabetes, heart failure, or any other disease will contribute to. So that really stuck in my mind as I went through then the next, the 20 plus years of my training, of my career, that housing is really not only about that broader ecosystem that I described of anchoring someone into their entire healthcare system, but it is also what impacts on a day-to-day basis how they exist as human beings. And so when I say that housing is a basic human right, I mean that. I mean that because those rights were being denied those three sisters. And our obligation was to address that in the context of their health care, because nobody else would if we didn't think of it as a human right and we didn't think of the link between that right and the impact on their health care. So as a clinician, I see that link so clearly, but also just from a shared humanity perspective, I see that link. To the second part, I work at the DeMock Center in Roxbury. You've all heard the statistics about the life expectancy being 23 years different from Roxbury to Back Bay. I look after a very diverse population. 50% of them are Spanish-speaking. We have a huge population of migrants who have just arrived. And we hear stories on a daily basis about how housing impacts that very particular demographic of the underserved population, but also new migrants and sometimes undocumented individuals. And it is as though everything that I've described is then put on steroids, right? So the housing insecurity, the poverty, the challenges with the other social determinants of health in terms of, for example, income, in terms of, for example, their ability to understand health information because of education levels and health literacy is exponentially different and exponentially worse. And so at the DeMock Center, we like to say we look after the whole person, but that whole person now becomes not only the individual, but it becomes increasingly the system that has resulted in this individual being where they are in terms of housing, but also our responsibility, therefore, to address that in a more comprehensive way, because they have truly no one else that would do so. And I'm going to end with an example of a patient who arrived in one of our offices a couple weeks ago, and she came here as a migrant and had been staying with someone for 6 months who all of a sudden now could not keep her anymore because the burden of keeping her had become too much in terms of the economic burden. And so she ended up on the street overnight, non-English speaking, 88-year-old, no family here, undocumented, nothing in terms of economic fallback on. And the only place she knew, even in that confusion as she dragged her bags across Roxbury, was, let's go to the DIMOC Center. I don't know much about them, but I know that's where I'll get taken care of. So I got a call to say, here's what we have to deal with. Of course, it's 5 p.m. on a Friday, right? That's when it always happens. But what struck me was that nobody asked, why here? Why not the police station? Why not the emergency room? Why not this? Why not that? Why not the mayor's office? We all just immediately knew it was our responsibility, and it was nobody else's but ours, and made sure that we got her housed by the end of that day. So I mean, I don't boast for when I share that story, but I really do like to say that for that particular population that we serve in the DIMOC Center, in centers like that, we have an added obligation to be sure that the buck ends with us. So thank you.
And thank you for fulfilling that responsibility so well. Jesse, just turning to you, Homeowners Rehab develops and preserves affordable housing that keeps lights on and is warm, and also develops supportive housing. Can you talk to us a little bit about the different types of supportive housing and what are some of the challenges in both developing, financing that housing?
Yeah, so at HRI, we have about 1,700 units of housing across Cambridge and 5 other communities, about 3,000 residents. And when we're thinking about particularly older adults, about 20% of our residents are over 60, and then another 11% are 50 to 59. And I want to circle back to that particular group because we're not talking about it, and I think we should be. So at HRI, we have large 300-unit buildings. We have one age-designated building that is 94 units of housing for older adults. That program, it's great because we have a resident service coordinator. We offer events and meals. We have a food pantry. We have monthly concerts with Shelter Music Boston where they come in and bring musicians from Symphony Hall and so forth. So we've got a lot of really robust program there. And then a large part of our portfolio are scattered site buildings where, we'll have 3, 6, 12, 18, 20, 30 units where we don't have dedicated resident services, where we don't have gathering spaces because the buildings are just too small. And so what we really are seeing is we have a wide range of different resident services needs there. And I think that there are a couple of issues that raises around how do we think about resident services and the different models that you're asking about. I think overall, we're lucky that in our larger properties, we have dedicated resident service coordinators who are highly trained. And I think we could all agree that across the Commonwealth, we just need more resident services for older adults, and we need clear funding lines because for most of us, we're not getting outside funding. This is coming out of property budgets, and there are a lot of limitations. We're lucky at HRI. We have a lot of properties, but there are lots of small multifamily owners who don't have those same resources, and so we just need some dedicated funding for the services side, particularly for older adults. So I think that's one piece. I think the other challenge that's related is inclusionary zoning is a wonderful thing that we have here in Massachusetts. And for older adults, it's difficult because there are not resident services attached. And when we're thinking about, Betsy, you were saying, people have to know about the ASAPs and the SCOs, and how do you get into those programs? And so if we don't have a way for folks who are in other kinds of housing to access those services because they're invisible to them or to homeowners, we have a problem. So we need to solve that in order to have really sustainable systems. I think the other piece is the more complicated piece, and I think this is where we go to the peril and opportunity conversation that we've had today. The embedded ASAPs and the PACE programs are absolutely a gift. I think what's challenging that we've seen, and we've had a lot of conversation with Somerville-Cambridge Elder Services about this, is there is a scale issue involved here. And so we really have to have, 100, 150, 200 units in order to have enough density for an outside provider to want to come in and work with us. We also have to be able to have funding for those dedicated services. And so that's going to be a barrier there. And for me, it makes me think about how could we get creative. In Vermont, they have the VASH program where they have an embedded medical and case management team. Started out in affordable housing, it has grown, so now you'll have that team working even outside of those buildings within a 1 or 2 mile radius. So how could we think about doing something like that? I ran a replication program when I was doing hoarding work in California, and we were having conversations with health insurance companies there about funding the construction of properties across a range of needs. So some of them would have medical clinics downstairs with on-site services, and then apartments upstairs for higher needs folks. And then we would have them also funding construction of, and the services side for other kinds of properties where people just rented and needed occasional help. But what the health insurance companies were saying was, this is going to make our operations cheaper because these are the folks who are not going to end up in the ERs quite as much, right? And so they're not going to have a medical crisis. So how can we start thinking about those kinds of creative options, given how resource rich we are here, and given that we know unhoused older adults are increasing, we know that we're going to have more and more older adults over time who are going to need sustainable housing. And then the last thing I want to say as we're thinking about how to approach this issue is, at HRI, 11% of our folks are 50 to 59, as I said. In our scattered site properties, it's about 10% of that population. And we right now are going to run into two buzzsaws, if you will. One is these are folks who over time are going to retire, become unable to work due to disability, illness, and so forth. And so those are folks who are going to have a financial crisis and struggle to pay market or moderate income rents. And so we need to be planning now for that from a housing perspective. And at the same time that those issues are coming, there is also going to be a need for increased services. And so the cost burden is already so high when you look at the cost of rent and the cost of services, that families and individuals already are struggling. And so when they're hitting the point where their incomes are starting to drop and their service needs are going up, we're really going to need to start planning now so that we're prepared.
Yeah, that's an incredible point, just to think about your current residents and how they're going to face a dramatic change, and what the impact is on the housing. So both Lisbeth and Betsy, just turning to you, can you talk about the different supportive housing models and how, in particular, they've been effective in addressing health disparities and health inequities? I know there's remarkable data from Two Life communities, and where do you see some of the key gaps moving forward?
Sure. So there's lots of different models and nuance to the different models, but I'd say that regardless of the actual model, there's just some fundamental pillars or building blocks that you really want to see in all of them. And I would say it's probably 5 legs to a stool. The first one, of course, being the foundation, as we've all talked about, of housing that people can afford. The second is that resident service coordinator, that person who knows the resident, believes in their hopes and dreams for themselves and helps those things come true, is fundamentally important in terms of dignity and quality of life. The third would be those kind of engaging programs and services. Jesse mentioned it, those concerts, those lifelong learning, those activities that keep people engaged and wanting to come out of their home and into community life, which is so healthful. The fourth being either site-based or coordinated access to home care and health care, again, that people can afford. And then the fifth one, I would say, is it's regardless of the model, it's a model where people don't have to move to get the care they need. You know, there are assisted living models out there. There are CCRCs that have levels of care, and you have to actually physically move to get the different care or the additional care that you need. And every time you do a move when you're an older adult, you become confused, you decompensate, and you become more frail. So the idea of creating living environments where everything that people need can come to them to create that stability, that predictability, and that sense of calm that really is tremendously helpful to health is really important. What I can share are just a couple data points on the impact of how we do it at 2Life. Again, it's, you know, we're an independent living provider, but we are, you know, wraparound with all of those legs of the stool included. And we do know that social interaction and addressing that issue of loneliness is key to keeping people healthy longer. The SASH model that you referred to that includes the combination of a wellness nurse and a resident service coordinator is shown to significantly decrease spending on the Medicare side. That's huge. At 2Life, we have been able to compare ourselves via a HUD study that was done a couple years ago of all the housing nationally that was built under the federal 202 program, which is a supportive housing model for extremely low-income folks that we need a lot more of, and it needs to come back more robustly. But looking nationally at 202s, the average age nationally that people leave 202 housing for another level of care where there isn't as much support is 79. In Massachusetts, on average, people leave 202 housing at the age of 81, 82, and at 2Life, it's about 88 or 89. So that we know the addition of the resident service coordinator, all those programs, and the care coordination is keeping people living in community for a much longer period of time. And another data point with 2Life, at any given time, roughly 30 to 40% of people who live with us need help with at least 2 to 3 activities of daily living, which technically qualifies them for nursing home level of care. Yet only 2% of our residents leave us for a nursing home in any given year. So we are keeping people living with us for a very long time with this coordinated service that's coming to people in their homes. You know, that site-based access to care, and particularly having that person who knows and cares about the needs and has that trust in the community every single day can head off so much, which is a huge savings on the healthcare side. And, you know, just as an example, we always talk about Mrs. Schmedlap when we talk about examples, but this is a real story. We actually have a care coordination partnership with one of the SCOs, where we have about 200 residents in our community using the same SCO. So we are coordinating, and our resident service coordinators are part of the care team for these 200 folks who are members of that SCO. And one of our residents came home from a hospitalization. We typically wouldn't know that, but that we're part of the care team, and we get that report. And our resident service coordinator went and checked on that person when they came home from the hospital, and they were literally about to call 911 because they didn't understand their discharge plan. They couldn't decipher their medications, they couldn't get a hold of them, and they were scared and didn't know what to do. And our resident service coordinator helped them call their care coordinator at the SCO and got that clarification, and they stayed living with us. We also have other features in our housing. We have 24/7 site reps, we call them, but we always have at least 2 apartments that we take offline in our community. So after hours and on weekends, there's always someone there to answer the pull cord. Because of that, we head off. 911 is called and an ambulance comes. It results in a transfer to an emergency room, which typically then, you know, leads into further decline. And, you know, I would say now, just kind of turning to the gaps question, I think it's a hugely important one, and it really brings us back to the commission, and it brings us back to what I would say are 2 fundamental challenges. One is we have a terrible supply challenge. You know, CHAPA several years ago did a study and looked at all the people in the state who are unserved by affordable housing. And particularly, they were looking at data that would encourage expansion of our state MRVP, which is like a state Section 8. And they found that 51% of the population that's unserved, that's eligible for subsidized housing, is over 62. So that is dramatic. So we have a huge supply problem. But not only do we have a supply problem, we have a terrible misalignment problem in the production resources that are out there, both simply to produce the housing with rents that meet the needs of the incomes of older adults, but also, as Jesse mentioned, really are thoughtful of all the resources that it takes to do the resident service coordination and provide all those programs, which we know are saving on the healthcare side. And I think, did you hand out the chart already? That, oh, so if you shoot your phone at that, we provided this, we call it the red box chart, but you'll all find this. And essentially what we did was we looked at the housing ecosystem, the LTSS ecosystem, and the healthcare ecosystem, and looked at population demand and need and eligibility requirements. And the punchline here is that the vast, vast majority of older adults are below 50% of area median income, and the vast majority of those are below 30% of area median income. Yet our only housing production program right now, the key driver, is the tax credit program. And to be tax credit eligible, you need to earn at least $45,000 or $50,000 a year, which doesn't represent the vast, vast majority of our population. So the people we can produce housing for cannot afford the rents if they're over 62, and they certainly can't afford home care and health care on top of being tremendously rent burdened in tax credit housing. For example, in the greater Boston area, tax credit rent is about $1,800 a month. The program was developed for families who are working and earning limited income, but whose income go up over time, not older adults who have fixed incomes that arguably go down over time as cost of care goes up. So a typical older adult at most could afford $1,000 or $1,200, and that's before you start considering the cost of care, which, if you're not LTSS eligible and you have to buy it in increments of 2 to 4 hours, you're easily spending, $30,000, $40,000 a year on care on top of your housing. It is just simply not sustainable. So realigning this entire system and looking at the demographics of who the population is we're trying to serve, and to really be thoughtful about how we knit together all the components that we know are saving resources on the healthcare side and are really providing the kind of dignity and quality of life that our older adults deserve is something we really need to get at in order to do this right going forward.
Thank you, Elizabeth. Yes, a clear mismatch between funding and the kind of housing we need, and we need to solve for that. Betsy, what would you add there?
I would add, that was very comprehensive, and I would like to say I have seen an earlier version of the chart, and it's excellent because it tells a story that is complicated in a fairly easy to read way, and a really important story. One of the gaps is we should have resident service coordinators in every single affordable senior housing building in this state. We have them, by my estimation, in less than 10% of the buildings across the state. So we have a very long way to go. And you may say, you're always asking for more funding, you're always looking for more money for projects, or this goes to everything we've talked about today. If we could provide the least expensive care, why wouldn't we do that? As opposed to, so having a resident service coordinator, it is not a huge sum of money to have somebody, even 24/7, which I think is the ideal model, versus 10 people in that building unnecessarily going to the hospital for 2 weeks, ending up in rehab for 3 weeks. The cost of that is astronomical. And do some people need to go to the hospital and into a rehab? Absolutely. But so many people don't. Our healthcare system is completely reactive. You only see a doctor, go to the hospital if something's happened. This is a completely preventative, upstream, as far upstream as you can get. You're in somebody's home. You can't get much more upstream than that. And it's always so revealing when somebody opens the door of their home and you walk in. You may have certain perceptions of someone because you talked to them over the phone or you saw them on Zoom, and then you walk in and you are like, oh my goodness. And there's 22 cats, and there's all sorts of other things. So you can't beat the model. And when you look at the slide of how expensive our healthcare system is and how terrible our healthcare outcomes are, why aren't we thinking about doing it? Like, literally, if for older adults you could redo our entire healthcare system, that's what I would focus on first. All the social care pieces, what happens in somebody's home, and then build out from there. And it would just make a lot more sense and save a lot of money. So that's just another plug for this program, because you really can't beat it. It makes so much sense. And it also, in some respects, and maybe this is pie in the sky, but I do see it as an equity issue, because no one I've ever worked with could afford to go into assisted living or into a community, continuing care retirement community. Why not develop in-place assisted living and affordable housing? So maybe you have to move a floor, but you can still stay in that community. Maybe you don't have to move from the apartment you've been in for 25 years in the town you've lived in for 86 years. Like, thinking out of the box to the point that Jesse made, and respecting what home and community means, I think those are just starting points for helping us rethink how we're providing services and how we're using or not using affordable housing as a platform.
Thank you. I think we have about 3 minutes left at this point, maybe 2. Jesse, anything you'd like to add just to the model? It's hitting me now. It's like our entire resident population in affordable housing is going to need elder care and supportive services. So how do we turn that on its head? And maybe the last minute, Dr. Wong, you could talk about some of the key partnerships that you rely on to, for instance, finding housing for the senior that you spoke about. So Jesse.
You know, I think Betsy summed it up so nicely. We just need more of everything. You know, I think the way that I think about this, though, is when I was doing hoarding work, nobody wanted to do it. We were evict first, ask questions later. And what we found was, there was a report done a number of years ago, and it's probably much more expensive now, but there's a report that found that the cost of eviction, not for a hoarding case, just an eviction, was $10,000. And so we started doing the math when I was at Metro Housing around, well, we have this many hoarding cases, and so that's this many evictions. It's a lot easier to start a program, get people trained, and do preventative work. And so I've found myself thinking a lot today about that kind of math, where we're thinking about prevention. The other piece that I'm curious about, it's not fully formed yet, but what would it look like to have an opt-out system instead of an opt-in system in terms of access? Because right now, you have to know about the sources and know how to get there, and it's a little bit of a wing and a prayer. But what if we made it easy to get the sources, and if you don't want them, that's great. We'll move on to somebody else who needs them. But maybe it's time we start having a different kind of conversation about that.
So that segues very nicely to my last point, which I'll make in a minute. When Colleen called and asked if I'd take part in this panel, I said, of course, after everything you've done for my patients. And that was a real partnership that I saw created the trust and the relationships that were necessary to deliver the type of care I wanted to give to my patients when I was a primary care geriatrician at Mass General Hospital. There I had the benefit of having a social work department, even with multiple social workers who had a very strong relationship with SCES, so that when I dealt with the patient's 35 medical issues and we hit something like this that was beyond my bandwidth and my scope, even, or my area of expertise, I could step out of the exam room straight into the social worker's office. They will call SCES and everything will be taken care of. So till we build more and better, we have to think about how we access what we have now. And primary care, I don't need to say, is under tremendous stress, and part of it is because we don't have the ability to get the resources we need to deliver the kind of care we all went to medical school to give to patients. So I will say an example of an excellent partnership has been SCES over 2 decades, and I hope that other providers have access to services like that.
On that note, I also want to thank Colleen for being so incredibly organized and putting this panel together and our materials. And Marta, thank you so much. And thank you to our panelists.